Hello and welcome to our first live Q&A titled Integrated Psychosocial Care for DGBI, How to Get the Most Out of the Resources You Have. I am your host, Tanya Murphy, Executive Director of Rome Foundation, and I'm really excited to be here. I'm going to introduce my co-host, Dr. Doug Drossman, who is the CEO and President Emeritus of the Rome Foundation, President of the Drossman Center of Education and the Practice of Psychosocial Care, and I have to add one more, Professor Emeritus of Medicine and Psychiatry at the University of North Carolina in Chapel Hill. Our expert today is Dr. Laurie Keefer. Really excited she's here today. Just wonderful, wonderful expert. She's one of the Rome Foundation members who co-founded the GastroPsychological Section, along with Dr. Sarah Kinsinger. GastroPsychology has more than 400 members around the world committed to the evidence-based practice of integrated psychosocial care for DGBI. She's a professor of medicine and psychiatry at the Icahn School of Medicine at Mount Sinai in New York City, where she directs the Inflammatory Bowel Disease Integrated Care Program. She has held the NIH funding for more than 15 years in the area of behavioral intervention design for chronic digestive disorders and is now a champion for integration of behavioral techniques into routine GI care. She is also internationally recognized for her advocacy for the inclusion of GastroPsychology in the management of DGBI and is a sought-after mentor, speaker, and collaborator. Dr. Keefer has authored more than 200 publications, co-edited the Handbook for Psychogastroenterology for mental health professionals, and co-founded the company Trellus Health, which is a chronic care management solution for IBD based on her resilience-based methodology. And I know that was a handful, but very well esteemed. So excited to have both Laurie and Doug with me here today. And I'm going to now turn it over to Dr. Doug Drossman.
Thank you. Thank you, Tanya. I just want to say it's good. This is the beginning of a series. Tanya and I had the idea to bring back these Facebook Lives for two reasons. One is they're very popular, and we're going to educate all of you on a lot of the new areas in DGBI. The second reason is we have a board of directors that are remarkable. They're all highly accomplished in their field. And why not bring them week by week to us to expand upon their knowledge? And in that regard, welcome, Laurie. We've known each other, oh God, maybe 25, 30 years.
Yeah.
but it was really great getting to know you in the last 6 or 7 years when you came on the Rome board.
Mm-hmm.
And from the outset, you had this idea to bring in psychologists, which of course you were doing. You were embedded in GI programs,
Mm-hmm.
but you had the idea to expand on this and created the GastroPsychology group, which has exploded.
Mm-hmm.
I mean, you use Rome as a platform to create your own world of psychologists through the GastroPsych group, and how much impact that's having. It's remarkable. So I think it's really fitting to just ask you a few questions about all of this.
Sure.
And one of the things that you also brought on is giving the psychologists not just to be embedded in the program, but to be part of the program in an integrated fashion. And you brought out the concept of integrated care. So let me start with the first question. What do we mean by integrated psychosocial care?
That's a great question. I think that, word can kind of get thrown around a little bit, but when we're talking about integrated care, we're not just talking about adding a psychologist or referring to a psychologist for your disorder of gut-brain interaction. We're really talking about the concept that it takes a village to treat these chronic conditions, and that we need to expand our team of professionals, whether that's a psychologist, a dietitian, a physical therapist, a nurse practitioner, to really make sure we're hitting all all of the different angles of DGBI care. And so when we talk about integrated, we're talking about communication that's happening between the doctor, the patient, and the other members of the team. And that's a reciprocal communication. So I always say, for psychologists embedded, we're looking, before we even see a patient, we're looking at their medical record. We're trying to understand what's their anatomy, what's their physiology, what medications are they on, what might be the impact of those factors on their mental health. And then when we kind of get them into our center or into our practice, we're adding on a real way of mapping what we call their brain gut journey, right? So what was your diagnosis? What was your experience with it? How are you perceiving it? Do you have hope and optimism? What is that connection that you have between your anatomy, your physiology, the way you've experienced your medical care to date? How much are you accepting of your diagnosis and your disease? And then the third thing we're looking for, which is more of the traditional psychologist role, we're looking for, do you have depression? Do you have anxiety? Do you have post-traumatic stress? What are these influencers that kind of happen? Once we're able to do that, that's when the integration occurs, because then we can decide with the team, what are the key behaviors, skills, outcomes that we want to target for this particular patient. And that's the integration piece, that personalization of care, that I think is really, really critical to seeing improved outcomes.
And what I've seen and heard about what you're doing is it's not just a bilateral you with the patient, but it's a collaborative. I mean, so that you're providing information to the provider, the gastroenterologist,
Yep.
and then they're working with you in an ongoing way. Can you say more about that collaboration?
Yeah, I mean, I think that's really, really critical, that it's not just a one-way, you're referring, as a gastroenterologist, you're not just referring your patient out to the psychologist and telling us to work with their stress management. I'm going back to my physician colleagues all the time saying, what do you think about this? Or have you thought about this? Or did you know about this? I mean, you and I have worked on cases, and, when patients have they have different experiences with different professionals. And so I might hear one part of the story, you might hear another part of the story. And when we're both of us talking, we come up with novel ideas. And so it really is that communication. It's also, and obviously, this with all of your work in communication, it's also around helping the patient communicate better with their physician and vice versa, right? And so sometimes for me, it's bringing a little bit of a background to the physician about why the patient might be presenting a certain way, or why they might be feeling anxious or concerned, that the physician didn't realize. And then I can also say to the patient, when you're doing this, your doctor doesn't know this. And so this is a way you can sort of assert yourself and advocate for yourself. So psychologists really sit in that relationship in the middle as much as they are interacting with each of the people on either side.
I can recall a couple of times with some of our shared, more complex patient scenarios
Mm-hmm.
where I would call you up and we'd have a guess what, and that could be a positive guess what or a
Yep.
negative one that we had to work on. So
Yep.
yeah, it's very reassuring to have that kind of collaboration.
And we can also, I think even from a provider perspective, working in integrated teams reduces burnout, right? And making a point to celebrate our successes, right? And say, hey, I saw this person, they're doing so much better. Thank you for your help with this case, or, vice versa. And I think it kind of decreases that isolation for the patient, but also for the providers who are often, seeing patients on the 15-minute situation, and to know that they have a team that's also celebrating their successes is really nice.
Yeah, I agree. I mean, one of the universal features of burnout is the person feeling isolated,
Yep.
having no resources.
Yeah.
Well, so you've created this concept of gastropsychologist.
Mm-hmm.
And what do they do? What are the types of integrated care that we can talk about?
So, we're really trying to hone in on, we've really tried to recognize that not every practice is going to be able to embed a gastropsychologist, even though that would be my dream. And part of that is just a supply issue. There's not enough of us out there that can really do that. And then, demand wise, there's a lot of pressures on the health systems to be able to generate revenue and all of those things. So the business model doesn't always work out. So I would say that what I have at Mount Sinai, what we did at Northwestern, what you've had at UNC, where you really kind of have that embedded psychologist who's part of the faculty, who's, right there in the clinic, so that when you refer a patient, they're making appointments with the same schedulers on their way out. They're coming to the same waiting room. It doesn't feel so much like they're being sent off to psychiatry or sent off to some other facility is the goal. That's the gold standard. That is ideal. That's where we see the outcomes, right? The mantra trial, the grit trial, all of these trials show that when you have somebody embedded that's a psychologist, it's not just here's a patient you can refer to within your practice. It's the programmatic component. It's creating that psychosocial culture. What we've learned to do, though, is take elements of that psychosocial culture and see if we can make it a little more accessible with lower levels of resource. So, we kind of think of that level 3 resource of having your embedded gastropsychologist, which we can always talk about. But I think level 2 is what we're calling sort of that non-mental health professional assisted psychosocial care, right? And that's sort of trying to elevate what practices might be doing, even though they don't have an embedded psychologist. Now, that might mean they have a psychologist who pops in once a month. That might mean that they have somebody in the community that they refer all their patients to. But that might also mean that they're having nurse-led support groups, right? There's a plenty of science behind self-management, programming, stress management, supportive counseling, education, lifestyle, sleep, exercise, that doesn't need to be offered by a gastropsychologist, and in fact can really be done quite nicely with a nurse practitioner, a physician assistant, things that are part of every GI practice anyways, right? And so it's not just sending the patient out, but really kind of building up that culture of we're here to manage lifestyle and mental health and emotional support within our practice. So that's really level 2. And also within level 2, I would say is this the gastroenterologists ability to be able to manage low-grade mental health concerns, right? And so obviously you've done a ton of work on being able to prescribe central neuromodulators, tricyclics, SSRIs, SNRIs, right? For pain. And what I would say is that to be a level 2 psychosocial community or integrated program, I would love to see the gastroenterologists be able to prescribe an SSRI, for example, for mild depression, mild generalized anxiety disorder, really kind of have that added ability or comfort level, because it's so hard to get mental health care. And we know that those are psychological influencers. So if a person has generalized anxiety disorder, and also gastroparesis, irritable bowel syndrome, functional dyspepsia, what have you, there's no reason why we shouldn't be able to integrate that all into the GI setting. And then the other component of a level 2 integrated care is some of these digital therapeutics, which is sort of its own conversation too, but many of them can be prescribed alongside a provider who's kind of checking in to make sure you're following it and doing it and benefiting from it. And so I would say that could even fall into that level 2 integration. Level 1,
I want to get to that more a little bit later. Yeah.
Yeah. And then lastly, level 1, which what I would say should be part of any DGBI care, is that our physicians know how to spend the time educating the patients around the gut-brain microbiome axis, the role of brain-gut behavioral therapies, and centrally mediated interventions for these conditions. And then the encouragement of self-directed lifestyle. So whether that's your patient says, I'm having trouble sleeping, and you encourage them to download an app related to sleep. They tell you that they don't exercise well enough, and you encourage them to join a gym. I think that is table stakes, something that our GI docs should be able to do, that I would love to see as part of creating that psychosocial framework as part of management of DGBI.
You know, I'm thinking about other models, for better or for worse. IBD is an example where a lot of the day-to-day work is handled by nurse practitioners or physician assistants, and the provider is mostly doing the endoscopy or briefer clinic visits. I don't think I want it to go that way for the neurogastroenterologist, but I'm wondering, as time goes on, as more and more patients are being treated this way, do you see a role for training APPs, nurse practitioners, where they could be part of the team, physician assistants, and working with the GI doc to make it more of a larger system in addition?
No, I think that's exactly right. I mean, I think that that's an access, it's a way of addressing some of these access problems. You know, nurse practitioners in particular, nurses in general, are really trained already in the biopsychosocial framework, right? And so they're already very comfortable with brain and gut, regardless of what their background is. They're also very well trained in facilitating self-management behaviors in patients, and empowering and educating. So I think that there are just sort of basic skills. We also know, I mean, there's been a few studies lately, one of gut-directed hypnotherapy delivered by nurses out of Magnus Simran, one of our board members groups. We have seen Helen Murray, who's one of our working team report Rome members. We've seen her work training nurse practitioners in exposure-based cognitive behavior therapy. And we saw the really large nurse-delivered randomized control trial out of the UK, Hazel Everett's group, where they also showed in over, I think, 600 patients that they were able to reduce GI symptoms as a consequence of participating. So the data, I would go so far as to say that evidence is there that nurses can deliver this. With Dr. Burton Murray's work, she also looked at feasibility and acceptability. Patients thought it was totally fine to be receiving this type of specific targeted intervention by a nurse practitioner. So I'm pretty hopeful about that. I think nurse practitioners, again, are really on the front lines. And this is a great way to, again, in-house provide a lot of the basic interventions that we know to be effective. From a gastropsychologist perspective too, like, we would rather see the more complex cases, and a lot of our patients don't need a gastropsychologist. They just need some basic behavioral skills training, and that really can be outsourced.
And if you're integrating the system, you could be available to the provider with questions without having to see the patient.
That's exactly right. And that's, definitely an initiative that we're looking to expand through the Rome GastroPsych program, would be courses and curriculum really focused on training non-mental health professionals in some of these brain gut behavior therapy techniques.
Well, let me ask more about the digital therapeutics, because I see pros and cons. The big pro could be for someone, well, they're taking responsibility for their care, they're doing it on their own, and that could be highly motivating and lead to a positive outcome. On the other hand, a lot of the patients I might see are gastroenterologists, and with more complex patients, it may not be enough. Could it even be harmful? So can you talk about which programs there are and the pros and cons?
Sure. Yeah, I think I totally agree with you. I think it's, I really have mixed feelings about it, right? I mean, on one hand, I am so pleased to see that these brain gut behavior therapies have hit the field so hard that there's companies that are actually trying to replicate it and increase its access to the masses. I think a couple things. So, the pros, as you said, are, these are stigmatizing conditions. There are plenty of patients who may not want to even talk to a doctor about their GI symptoms, or may not want to share their diagnosis or have it written down in their medical record or what have you, that really may find some solace in there being an app out there, right? And identifying with some of the psychoeducation. I think a lot of these apps do a really good job with the psychoeducation. What's the brain gut connection? Why do behavioral strategies work for patients? So I think that that's a really great way to get the word out. I think the other pro is that, there's a lot of time in between office visits that patients have to manage their condition. And so even if you're working with a gastropsychologist or a nurse practitioner, there's a lot of time in between those office visits where you could benefit from some skills, right? And a lot of these apps might have an in-the-moment relaxation or a, hypnotherapy session that you could kind of do to self-manage. And so from that perspective, I think self-management, self-directed, skills that we know are evidence-based is really great. I do want to point out, though, that we are really referring to these digital behavioral interventions as self-directed self-management tools, right? Where these are not brain gut behavior therapies, and brain gut behavior therapies are clinician administered, right? And they are theoretically based on a personalized set of characteristics for the patient. And so I think going into the cons, one of the cons is that I think we have to be really careful not to conflate the downloading of an app, the participating in a CBT or a hypnosis app protocol as if you are receiving a brain gut behavior therapy, right? And if it doesn't work for you, it's not because you failed the therapeutic class. It's because you needed a different delivery mechanism. You needed a different dose. You needed more personalization than an app can offer you. The other con is that many of our effective self-management apps are related to single behaviors, right? So I don't sleep well, I'm too stressed, I can't organize my time, I don't know how to boost my mood, right? And so there's an app for almost every single one of those behaviors. It's not as common, and I think this is where maybe some of the digital therapeutics are struggling. It's not as common to have an app for a syndrome, a complex heterogeneous syndrome, right? And so I think, throwing an app at something as heterogeneous as IBS, for example, which is where most of the digital therapeutics are right now, can be really difficult because you have different subtypes of IBS, you have different manifestations, different degrees of pain, different degrees of impact. And because it's not a single behavior you're targeting, it can be a lot harder to show movement.
Yeah, good point. And we struggle. I mean, I know with Rome 5, with all the committees, all the data is with IBS. Are we talking about IBS, or are we talking about a process that's encompasses all the conditions? Right. I think I lean more toward the latter, that we're than specificity.
Yeah, and with gastropsychology, I mean, I think a gastropsychologist, sure, we have most of our randomized control trials in irritable bowel syndrome, but the theoretical framework of targeting cognitive factors, affective factors, behaviors related to symptom perception really translates to any of these conditions with a little bit of tweaking, right?
And it's moving out to IBD and celiac disease. Right.
Yep.
Well, moving forward, what would be the future of psychosocial care? And let me begin just to mention one point, that as I look back, we've set the stage for the integration of these factors just by the terminology we use. 10 years ago, we were talking about functional GI disorders, which supported a dualistic concept of mind-body dualism, that these were psychiatric problems because we couldn't find anything structural.
Mhm.
And then the next thing we moved on to was, let's talk about neuromodulators, because the functional GI turned into disorders of gut-brain interaction, which by definition implied dysregulation of brain-gut axis. Subsumed under that was everything from the microbiota to visceral sensitivity and brain-gut interactions. And then we moved on to treatments, and the treatments are using neuromodulators, not antidepressants,
Yep.
anti-anxiety, and antipsychotics. And now, thanks to your work, we're calling it brain-gut behavioral therapy or treatments, not psychotherapy.
Yep.
So I don't know if you want to comment on that, but then tell us more about the future.
Yeah, I mean, I think I'm a big believer that the language we use really matters. And I think that, I think even the example that Rome started with irritable bowel syndrome, right? Like labeling that as an actual syndrome that has a positive diagnosis. It's not just we can't find anything, so therefore that's what you have. I think Rome has always been very thoughtful and intentional about, destigmatizing both the development and treatment of these conditions. And so certainly words like central neuromodulators instead of antidepressants make it a lot easier, not just for the patients to receive the information, but for the physicians to talk about these topics, right? I mean, you know this in your career. You've spent a lot of time on communication of these complex problems, but I think the more precise we are with the language, the less stigmatizing we are with the language, the more accurate we are with the language, the better the providers are able to actually confidently talk to their patients about this, get buy-in, get access to treatment. I mean, uptake of a neuromodulator, uptake of a brain gut behavior therapy has increased dramatically. Think of all the patients we're able to treat now much more holistically because we've spent the time on the language. I think the other area of language within gastropsych that we've really worked on is identifying our targets of our intervention, and the techniques that go along with those targets. Again, it's not psychotherapy. These are skills-based coping strategies. These are sometimes even with hypnosis, for example, these might even be subconscious ways of talking to the brain-gut axis that really kind of, again, foster the science of it. And then once we have that language, when we go to publish, there's a research impact too. When we go to publish a paper and we're all talking about the same way of describing our treatment targets, our techniques, who's done the therapy, what type of therapy it was, we increase our ability to say, wait, these aren't just low evidence interventions. These compete with drug interventions, right? We become much more rigorous. And I think this is where the future holds, as you were asking. We're really improving the rigor with which we report on these treatments, the way that we are systematically applying them across settings, and talking about mediators and moderators. And I always use this example. When I trained in CBT for IBS back in the 90s. And we had a grant and we were applying CBT in a group setting. That was the novel part, that it was a group delivered CBT. But it was based on this idea that IBS was a physical manifestation of generalized anxiety disorder. Your stomach ache meant you were a chronic worrier. And that worked for the patients who had stomach aches due to chronic worrying, right? Chronic worrying doesn't help anything. And so if you treat that stress and worry, you might feel better physically. Now we don't even talk about that, right? Now we're saying CBT targets catastrophizing, perception of the brain, fear conditioning, avoidance behavior, coping strategies that might have made sense early on before you were diagnosed that no longer make sense. We're reducing the level of threat at the level of the brain when you experience a GI sensation we're targeting the threat value of it. All of those changes have allowed for us to actually compete scientifically with the pathophysiological interventions that are out there from pharmacology.
That's a huge paradigm shift, because we were dealing in the older days from the older psychosomatic concepts with stress causes these GI problems. And now we're saying your GI problem is the stress. And what we're teaching you to do is to reduce that distress.
Yep.
And in doing that, you'll be relieving your symptoms, not the other way around.
That's exactly right.
Well, that covers our topics. I want to thank you for providing these insights. As you know, this is not only live, but it will be on our Rome website for others to learn from it. And Tanya, let me turn it over to you. Any other final words?
Yes, even with all of my history so far with Rome, I'm still just overwhelmed and just, enlightened by how much you can bring with your expertise to the table in self-care strategies and what should go to the app and what should be physician aligned. So really, really appreciate your time today and enjoy the talk. And I'm sure it will help so many more people out there. So thank you, Dr. Keefer, so much for being here today.
Thanks for having me.
Thank you. And this will be posted several times on Facebook. So thank you, everybody. And I hope you enjoy that.